unless you're asking a question. It would be great that if you do ask a question, to put your camera on if possible. It's nice to see a face behind the voice. So thank you all for coming to the Pelvic Health Why It Matters. This was a big request from a lot of our physio colleagues to have a session on pelvic health as a kind of a gap of knowledge. And I'd really like to warm welcome to Rosie Cardale, who is a pelvic health physiotherapist from the founder of Mae. And she'll be running our session today. So I'll hand it over to Rosie. And with regards to questions, we find that it might be as we're going along, we'll open the floor to questions as we go through rather than at the end. So if you do have any questions, either raise your hand, we'll come to you, or put your question in the chat and we'll get to you. I'll be monitoring that.
Thank you, Lily.
All right.
Right, let me just share my screen and present through here. So I can't see you, and Lily is going to be taking questions, which I'm happy to answer throughout the session. So if, as Lily said, if you have questions, send them over on the chat, and I'll take regular breaks so that they can be answered as we go. But there's definitely a chance at the end, if you have questions that you want answered, or you can write them down and then ask me them then. So as Lily said, this is in pelvic health, in my mind, is a really important part of health. So we're going to explore it in a bit more depth and hopefully give you a good overview of why it is important and why it does matter. So I'm Rosie. I'm a pelvic health physio. A pelvic health physio, in my mind, is anyone that is interested and specialised within this area of health. This area of health and the things I'm interested in are almost any part of your anatomy, from your ribs all the way to the tops of your thighs, and any muscles, joints, and particularly functions within this area that we have every single day of our lives. How I got into this area, I actually started my career really wanting to be a sports physiotherapist. I imagined myself running onto those rugby pitches, helping rugby players, but I have never been on a rugby pitch in my life. I had the opportunity to move to Bristol about 2018. And at that time, I rotated into the women's health team at St Michael's Hospital and realised that women were actually struggling with daily functions and also some of the sports that were keeping them fit and active. And what I now love doing is marrying the two aspects of that part of health, the sort of everyday function, with problems with pelvic health. And I think pelvic health is a really important part of healthcare. I've since left the NHS. I work fully privately now. I have 4 days a week with a busy clinic at Bristol Physiotherapy Clinic, and I do a day a week where I do things like this in educating healthcare professionals and women and children. So I go into schools and educate people on the importance of pelvic health. So not only will we go through why pelvic health is important, why it matters, but I'm hoping that you leave with an understanding of some basic pelvic floor anatomy, an understanding of the function of that muscle and the structures within that area. Also, we're going to go through some abdominal wall function and anatomy. This is something that comes up particularly in the postnatal population, and in primary care you might see this or be queried about this a lot. I also hope that you understand some basic things that you as healthcare practitioners are able to do to help troubleshoot pelvic floor related problems with people, look at some management of a condition called diastasis recti, and then things that you can implement into your own practice and point you in the right direction for some really good learning resources to help develop your practice as well.
Oh, Rosie, sorry, you're on mute.
Sorry, thank you. So why does pelvic health matter? So some interesting data came out between 2017 and 2018 that looked at how much money was spent on particularly prolapse treatments within the NHS. And £45 million was spent by the NHS on prolapse treatments. And these are generally towards the end of somebody's life, or sort of later stages of life. And interestingly, particularly as we're all from the Southwest, 25% of that total figure was spent in the Southwest alone. And actually the Southwest are one of the highest spenders in terms of treatment for pelvic health conditions, with most likely to be surgery, above actually London. 1 in 4 women will have some form of pelvic floor dysfunction throughout their lifetime, and it's not just exclusive to the postnatal population or the menopausal population. I see lots of women at any stage of life, and actually some of the Olympic athletes that you saw competing in the last 2 weeks have been to see me in clinic for pelvic floor dysfunction. So it's not just exclusively for people that you think X has happened to them, therefore this is going to be a problem. It can happen to anyone or any woman. And on examination, so this came out of the NICE guidelines in 2019, prolapse is actually present in about 50% of women. That's not always a symptomatic prolapse. It is possible to have asymptomatic prolapse, but on an examination, you can still present with it. So again, changes and ideas about pelvic health still needs to increase, and that is happening, but quite slowly. Some other statistics of why this area of health matters. Recently, the birth trauma inquiry highlighted that 20,000 to 30,000 of women will develop PTSD after birth every year. And also in this same inquiry, 84% of women who experienced tears during their labour and their birth felt that they did not receive enough information about birth injuries and the complications and risks of that ahead of time. The Women's Health strategy, which was published in 2022, also outlined the importance of how pelvic health, and obviously women's health, but pelvic health services need to be improved, particularly in the postnatal stage of life, going into the menopausal population as well. And education at schools, at the school level, also needs to improve. And the 2021 NICE guidelines also explored the psychological impact of pelvic health. So we're obviously not going to explore this in much depth today, but I think it's an important point to make that actually pelvic health isn't just about the symptoms that develop as a result of that dysfunction in the area. It's a highly embarrassing thing that can happen. It can really reduce quality of life, and it can have a big impact on women's mood and cause significant emotional distress. So it's a multifaceted part of our health, and there are often very simple solutions, as we're going to go through today, that can create and quite big changes to a woman's quality of life. So let's start with the pelvic floor, my favourite muscle in the whole body. The pelvic floor is actually more of a complex rather than one muscle. And that's what I would often see women coming to me in clinic saying, I don't know how to work that specific muscle, but it's actually a huge part. It's a bowl of muscle and fascia, membranes, sphincters within that pelvic bowl. It's made up and comprised of both superficial and deep muscles. So we have the more superficial muscles around the vulva, the urethra, and the anus, and then the much deeper muscles that move actually, this is one for the physios, move more anteriorly and cranially. So it has two functions to its muscle movement, both upwards and then forwards towards that pubic bone as well, which not all muscles in our body actually have that ability to do that. It's predominantly made up of type 1 fibers, which are our more slower oxidative endurance muscles, but it does have a mix of type 2 fibers as well, both fast oxidative and fast glycolytic. And these are more important for the rapid functions like the reflexive control that we need within that muscle function and system as well. So this is a general outline of the pelvic muscle and where you can see where that pelvic floor and all the muscles sit. On the left-hand side of the screen, you can see that even if you know your hip anatomy, a few of the hip muscles actually form part of this complex. So piriformis muscle and coccygeus muscle and obturator internus muscle over here, you often think more of internal or external hip control muscles, but they have dual roles of helping that pelvic floor. And I would say the same about almost any muscle that sits within and around that pelvic ring, into your glutes, your adductors, and your hip flexors. They can all have, and this is the part of that sporty aspect that I like, huge impacts on improving pelvic floor function if those muscles are also nice and strong too. The more important parts are all muscles that we often look at with pelvic health is the levator ani muscles. So these three, they, as we said earlier, they create that elevation of that whole group of muscles. If we're looking at it from the outside, you can see some more of these superficial muscles. So this bulbosponginosus muscle over here, the anal sphincters, and the superficial and deep transverse perineal muscles as well. So yeah, it's very complex, and that's just a brief summary of those muscles and the anatomy there. So what do these muscles provide function for? So the main 4 functions that the pelvic floor helps us with is our bladder function, our bowel function, our sexual function, and the upward support and lift of both pelvic organs and a few of those bones around the pelvis as well. Predominantly the pubic symphysis bone joint at the front, and then your sacroiliac joints at the back. If I just go back one slide, oh no. Then it's these 2 joints here and this joint at the front here. But it's not just about those 4 functions. With the bladder, it helps us with controlling our ability to urinate. It helps with the urge, and it also helps with that urethral support as well. The bladder is its own muscle in itself. So occasionally with pelvic health physiotherapy, we're trying to decipher with the subjective assessment, what is this a bladder problem, which is its own muscle, or is this more of a pelvic floor control aspect of the dysfunction that they're describing? We're not going to go into bladder function today, but it is, yeah, it's a different sort of muscle in itself. How the pelvic floor helps our bowel is it controls the passing of feces. It helps with the urge and detecting the urge, and also controlling that urge and giving us time to get to the loo. It does help with the process of defecation, and it also helps us to control the passing of wind. Sexually, it helps with our arousal. It helps to pump blood to the area. It helps allow penetration in its ability to relax and get ready for that penetrative act. And then it also helps with our ability to orgasm. And then from a pelvic organ point of view, it creates lift to those structures, our bowel, our bladder, and our cervix. It creates that upward support and stability, and then it stabilizes those anterior and posterior joints that we looked at. Does anyone have any questions at the moment, or has anything come through before we move on to the next part?
Nothing's in the chat.
Okay, if anyone has anything about any of that, then feel free to send a message, and we can answer it in a minute. So we've got a practical pelvic floor session now, and this is one of the there's a statistic that says that 50% of women don't know or aren't doing their pelvic floor exercises correctly. So hopefully by letting you understand how to do your pelvic floor contractions correctly, then that will help the woman that you're going to be seeing. So you can stand if you want to do this, or it's a bit easier sitting. So the pelvic floor works at its easiest in a lying position. So if somebody's really struggling with engaging their pelvic floor, then that's going to be your best opportunity to get it, to find it and isolate it and engage it in that position. It works next hardest when we're in a sitting position, when we've got the weight of our torso sitting on top of it. And then it works harder again in standing, when we've got that weight coming up through our legs into the pelvis to stabilize those joints and that area of our body. So it's got double the sort of workload going through it there. So if you're happy, let's stay in seated. I want you to uncross your legs, come nice and square in your chair. I educate women about, and men, and this will work if you are a man watching this too, that we can see on the previous slide, this is your back passage. If you can see my cursor, this is your vagina and this is the urethra. So if we drew a line between the back passage and the vagina, you can see that there's about 50% more muscle mass back and behind here than there is around this part. It's not to say that this part isn't still part of the complex, but on this image, you can see that actually most of the muscle mass attaches to the coccyx and at the back of the pelvis and then moves forward. So it has a pulling, remember it moves cranially and anteriorly, so it pulls in this direction. So what I want you to think about is more actually the structures and the muscles around your back passage. So sitting comfortably, nice and tall, relaxing your tummy. Take a few deep breaths in just to make everything relax. You're going to think about either holding in a fart or smuggling diamonds through customs in your back passage. You want to do this if somebody is watching you. You would see, I would see no movement either up off your chair or your tummy sort of pulling in. And that's the big misconception, is that there has to be a tummy engagement or abdominal squeeze with the pelvic floor. There absolutely doesn't have to be. And I would say that we often do that or want to feel that because the pelvic floor is such a subtle muscle. And very often, if we're a bit competitive, which most physios are, we want to then see something or feel something happening. And the pelvic floor muscle often doesn't give us that feeling. So then we think, okay, well, I'll just do this little squeeze as well, and that surely must be the right thing. So sitting comfortably, nice tummy relaxed. You're going to think about holding in that wind or those diamonds, and you aim to hold that for 10 seconds. Let's see if we can do that now. I'm going to count on the timer. And whilst you're doing that, keep holding. You're going to be wanting to maintain conversation, keep breathing, keep laughing, or keep singing. And then relax that down now. So let those diamonds drop back down. In the dropping or the relaxing part, you really don't want to force that down, because that would create this downward pressure that we're going to explore in a bit more depth later on in the presentation. You just want to think about that unraveling in that area. And I often describe that as ripples in a pond, or if the squeezing part had been like you've squeezed petals of a rosebud closed, the relaxing part is like you're letting that all unravel and open out into a full bloom. We know with any other muscle function that muscles really only have good function if they can both contract and relax. So it is an important part of pelvic health and how the pelvic floor system works. And the pelvic floor, or the orifice of our pelvis, is actually the second orifice to form when we're a fetus. So the first is our jaw, and the second is our pelvis, and they actually form roughly at the same time. So there is a link to sort of jaw TMJ tension and pelvic floor tension. And there's also another study that looks at the pelvic floor being the first muscle to actually respond to any form of stress. So it is a place that can harbour stress, and that muscle can become overactive, just like our shoulders can. So we need to be training both aspects of this as its muscle function, both contracting and relaxing. And I would say with the heightened awareness of Kegels, these are Kegels. Kegels is just a brand name for the professor who found and invented the pelvic floor exercises. And then since then, a brand called Kegel, who've produced pelvic floor training devices, has come about as a result of that. So Kegels are exactly the same as pelvic floor exercises or pelvic floor squeezes, and what you've just done there. So pelvic floor, it's important to be able to train endurance in this muscle. The evidence suggests that we should do pelvic floor exercises if we're asymptomatic of pelvic floor dysfunction once a day. We should train the endurance aspect of the muscle. So we should do 10-second contractions with good relaxation in between each repetition. And we should do 10 quick contractions. So we haven't done the quick ones yet, so let's practice those now. So you want to quickly lift that muscle on, so holding in that fart or smuggling those diamonds through customs, and then let it fully relax before you do your next quick one. You've probably all heard of the Squeezy app. The Squeezy app is a very good app and device that helps to educate women on this and also reminds them to do their pelvic floor exercises. If you are symptomatic of pelvic floor dysfunction, the evidence suggests that we should be doing these 3 times a day. So we should do our 10 long ones and our 10 short ones at 3 intervals throughout the day. I often get asked the question, I haven't been doing my exercises, do I need to start? And do they need to be done for life? And my answer is yes and yes. You need to start and you need to continue them. When we see an asymptomatic population of women that don't have any pelvic floor dysfunction, the importance of doing the exercises on a regular basis, it doesn't have to necessarily be daily, is actually more to maintain the neural pathway from your brain to that muscle. So it's helping you to reinforce the effectiveness of that neural pathway to the muscle function and muscle area. If that woman then goes through something that causes change to the pelvis, such as a pregnancy, a delivery, a trauma, a fall, a fracture, or starts to go through the menopause, the effectiveness of that neural pathway is as good as it could ever be. And all she has to do is then try to maintain that neural pathway to maintain and improve or maintain her function. So that's the reason I do my pelvic floor exercises probably 3 or 4 times a week. It's similar to strength training principles. We can see that people can maintain strength and improve strength if something is done on 3 times a week or has that regular stimulus. So, but there isn't any evidence to reinforce or help solidify what I've just said. The only evidence that we've got is that we do them every day, but I take that with a little bit of a pinch of salt and think about other principles of muscle function and muscle, the science behind muscles that we know from other areas of physiotherapy. So that's the practical pelvic floor session done. You can then, if you want to, your screen is off, or if you know, even if it's not, see if you can do the same thing in standing, where it's going to be a little bit harder. The gold standard is that we do them every day, every few days in standing, 10 quick ones and 10 long ones, or up to 10 seconds if we can. So what does pelvic floor muscle dysfunction look like? It sort of slightly leads on to what it provides us function for, but it can look like urinary and or fecal incontinence, urinary and or fecal urgency. That is then also difficult to defer. a heaviness, a pressure, a bulge, a dragging sensation in or around the pelvic area, pain with penetration and or orgasm, obstructive defecation, where somebody cannot defecate without assistance from either their digitally or a device that helps to allow the easier passing of stool, vulval or pelvic pain, and then coccyx pain as well, which might be something that more of the FCPs or MSK physios see a lot of too. Some of these are, for some women, are quite hard to talk about. And in terms of the subjective point of view with getting this information out to people, it can be quite difficult, particularly this heaviness, pressure, bulging and dragging sensation in the pelvic area. It's not always those words that are used. Sometimes that people can describe it as a tired feeling, an achy feeling. So yeah, it's definitely a skill to try and learn how to sensitively question this and try and dig for more information if it's needed at different times during the subjective assessment. So what are some of the risk factors for developing pelvic floor muscle dysfunction? So there's obviously modifiable risk factors and non-modifiable risk factors. Some of the modifiable risk factors are lack of exercise. Obviously, from a muscle function point of view, the less we exercise, the poorer the condition of our muscles are, both globally in our body, but also within that pelvic floor as well. Obesity, so BMI of over 25 kg per meter squared. Predominantly, that this seems like BMI is one of the risk factors because of the mass or the increased mass that then the pelvic floor has to support. So actually, it's more abdominal mass as well that should be looked at too. Chronic constipation, which is modifiable, but yeah, it sometimes is hard to modify. But the reason for that is that the chronic aspect of exposure to higher levels of intra-abdominal pressure to help that somebody needs to then defecate successfully. The pelvic floor has to cope with that on a daily or every few day basis, and that's quite tiring for that muscle, and therefore it might not get the chance to recover or strengthen to help with it. And the other thing that we've seen a lot of since COVID 2020 is a prolonged or persistent cough, and that's the same reasoning as the chronic constipation, is that coughing, and what we need to do to create a cough is increase our intra-abdominal pressure to expel whatever is trapped in our airways or is causing that need for us to cough. That pressure also not only goes up to help assist the reason why we're coughing, but also it has to go downwards, and that pelvic floor then has to cope with that pressure system and support that pressure system too. And over a long period of time, that can then weaken that structure or challenge that structure. Some of the non-modifiable risk factors are age. As we get older, and we know for women that we will then go through perimenopausal, menopausal states. Age reduces the quality and often mass of our muscle fibers. Doesn't always have to, but it is harder to then maintain muscle mass as we get older. Family history. So it's good to know what your mother or the woman on your side of the family have, what they've gone through in terms of their gynecological history and their obstetric history, because it can help you to then understand what yours might look like. And any hysterectomy or other surgeries will challenge or potentially interfere with how that pelvic floor and the structures within it work. Some more pregnancy specific risk factors are a maternal age of over 30, multiple pregnancies, and then pre-existing pelvic floor symptoms prior to becoming pregnant, which would indicate that the pelvic floor was possibly on the weaker side or had some form of dysfunction within it before then carrying a baby. It's actually pregnancy that causes the most changes to the pelvic floor. Obviously, labour and how we labour can cause changes to that muscle function as well. But when we're looking at C-section mums, actually it's the act of having carried a baby on top of the pelvic floor for 9 months that has the biggest change to the pelvic floor and how it works. So we can absolutely, and I do day in, day out, see women that have had C-section think that their pelvic floor has been saved and then have started to develop pelvic floor dysfunction symptoms in the early postnatal stages, or even in their pregnancy as well. Some labour-specific risk factors are an operative vaginal delivery, so a forceps delivery, and interestingly, the birth trauma inquiry, I can't think of the stats off the top of my head, but looked at how much in the UK we actually use forceps compared to the rest of Europe, and we use it a lot more than the rest of Europe. And there's some countries, particularly Norway, that have looked at trying to reduce their use of forceps, and they've done that successfully with using as baby's head is crowning, using a hot flannel or compress on the perineum, and they've reduced their use of forceps by about 50% over the last few years by doing that. So that would be an operative vaginal delivery, or anything which requires a episiotomy as well. An OP fetal position, so back to back. Second stage labour longer than an hour, which does happen quite a lot, and it's quite it's something to know and inform maybe your pregnant clients and patients about. But sometimes that has to go on longer than that, depending on baby's position and how the birth is going. And then third and fourth degree obstetric anal sphincter injury tears is another big risk factor for it. Any questions so far?
Nothing in the chat so far.
Okay. So the NICE guidelines published in 2021 have some really good recommendations for how we can prevent pelvic floor dysfunction and our non-surgical management of it as well. So obviously pelvic floor muscle training is up there, but it isn't just let's just get them to do their pelvic floor exercises. It is so much more multifaceted than that, and there are so many other things that can really help with it. Lifestyle advice is really important. So thinking back to some of the risk factors, obviously chronic constipation is one of the modifiable risk factors for improving our pelvic floor function. So if somebody suffers with constipation and they are reaching an age where they might think about becoming pregnant or are pregnant, then it's a really important thing to discuss with them about what they can do, whether it's a laxative or a stool softener, or thinking about their fibre or water intake to help reduce that risk factor and help their pelvic floor. There's two types of machines that you might have seen that for pelvic floor training. They are actually very different in how they work, and the physios amongst us might know a little bit about particularly the NMES, neuromuscular electrical stimulation, but the biofeedback machines. So these are the likes of some brand names are LV, HeriFit, and the Kegel 8 has got one as well. These machines you would pop internally, and the machine would pick up on a rise in pressure in the receptors and monitors that it's got within it. And that would then come up on your phone and it would say, oh, yeah, look, you're doing a pelvic floor, what feels like a pelvic floor squeeze. My one gripe with these machines is that they don't necessarily know where that pressure is coming from. So I've had women that have come to me and said, my PeriFit tells me I'm doing really good pelvic floor exercises, and I assess them, and actually that pressure is coming from a bearing down or a squeezing of their abdominal muscles, and it's giving them a false reading on their machine. So the biofeedback machines can be really good, but they really are only useful if that person knows that they are doing the right pelvic floor squeeze. And if they then like feedback or playing games on their phone to then improve their compliance with doing the exercises. The neuromuscular electrical stimulation devices are beneficial for women that have got, on an Oxford grading scale, a 0 or a 1 out of 5 in terms of their muscle strength. So they've got very little to no contraction of that muscle. And the electrical stimulation devices actually then help to contract from the external or electrical aspect of that stimulation, the muscle fibers, and that then allows that woman to feel what that pelvic floor contraction is like, and then they in time can help to join in with that, and that then helps their muscle to get stronger. Using the machine on its own without the woman trying to join in with it won't make that muscle any stronger. It has to come from the woman then trying to mimic what that machine is making the muscle do. There are some intravaginal devices, which I've linked later on in the presentation, which can really help with stress urinary incontinence and urge urinary incontinence. There's lots changing and coming out, and there are some that are available to prescribe on the NHS, particularly Contiform and another one called Devine. And I think the Contrail ActiGuard is now prescribable on the NHS, but I need to double check that. But these devices would go internally, so you pop them in a bit like a tampon, and the device would then stent the urethra, and that would then help to reduce the patient's exposure or prevalence of stress urinary or urge urinary incontinence. Pessaries are a very good tool for pelvic organ prolapse, and they can be used actually at any stage of a woman's life. There's some interesting data coming out of Australia where they're very proactive at using pessaries in the early postnatal population, and a study that is just about to be published has shown that actually the use of a pessary in a woman who've just had children or a baby can help to lift and support that pelvic organ tissue back up into place, and it can actually remodel what was a moderate prolapse more into a mild prolapse, which is quite hard to actually do with just the other things that we've spoken about, so pelvic floor training, lifestyle, and sort of strength work stuff. So yeah, in the UK we use them much more sort of reactively and later on generally, but yeah, they are very good if they can be used earlier. Then the current evidence is looking like it's going to be very good to help women there. Bladder retraining, we spoke about that bladder is its own separate muscle, but you can help with then improving the pelvic floor with managing frequency and then urge with that as well. Bowel habit retraining we spoke about, and then within that the diet and fibre advice. Other things that have been shown to help is strength training. So like I said, the muscles around the pelvis are almost like your second pelvic floor, and the stronger you can be globally, generally the better the pelvic floor function will be. Impact training, I think, from a sort of seeing women that are returning women to sport, is actually a really part of how we get that reflexive part of that muscle function, which normally will create dysfunction for stress urinary incontinence. But actually progressively overloading impact and women's exposure to impact can be really important to improve that aspect of muscle dysfunction. And then looking at progressive overload principles that we would apply to other muscles within our body to the pelvic floor muscle as well. So what can you do as GPs and healthcare practitioners? Early referral to women's health physio teams and all private physios. I know that there's a few of you that aren't in Bristol, but I know that the Bristol waiting list, particularly even for the urgent referrals, is increasing quite significantly. And yeah, so it's what should be a sort of 2-week waiting list to see women who have an urgent need is now increasing. So some of these things that we've just spoken about could actually help bridge the time of them then seeing more of a specialist physio. Get them started on the pelvic floor muscle exercises, which we've just gone through, and hopefully you're all now experts in doing that as well. Discuss that psychological impact that we spoke about, and that the NICE guidelines highlighted that actually it's not just the physical side of things, it's actually the reduction in quality of life or the emotional stress that this can cause, and see if there's any need for help with that too. If you can reduce the fear of exercise with these women, then that is one of the big barriers that I see in the private world, is that women are fearful of exercising and the complications and risks of it. Exercise, and how I frame it with these women, is that the symptoms that they're developing, and one of the biggest fears I would say of pelvic floor dysfunction is that the exercise, or what has brought on their symptoms, is worsening the tissue or the presentation of what they've got. And that this is much more so with pelvic organ prolapse, is that if they become symptomatic of that heavy feeling, of that dragging feeling, when they've gone for an hour-long walk, they're then fearful that that hour-long walk has worsened this tissue. And depending on when they're developing the symptoms, it's very unlikely that the act of an hour's walking is worsening the tissue. It would more likely be the event that caused the problem. So if they're 6 weeks postnatal and they're getting this heavy feeling, it's more likely that the birth that they had or the pregnancy that they had has caused the change for them to now feel these symptoms. And that act of walking isn't changing the presentation, it's just tiring the muscle sling and support and bringing about symptoms. I liken it to knee pain. If you went out for an hour walk and you started developing knee pain, you wouldn't then suddenly think, gosh, my knee's now going to fall off. You'd think, oh, probably that's maybe a little bit too much for the structures around it and everything's got a little bit tired. Next time I'll maybe do 50 minutes and see if that same sensation comes on. And if it does, and it settles within a sort of 24 to 48 hour picture, then you are definitely not worsening or damaging tissues. The tissues are just fatiguing. So sometimes using that analogy to help women to not become fearful of what they're doing is useful to then, because actually that exposure to exercise helps to strengthen them globally, and that increase in global strength then helps with their pelvic floor, and their pelvic floor will almost get carried along with that. But this reduction of, or this fear around exercise, I think is something that could then lead to a continual reduction or fear of exercising that goes on way past their sort of baby or child rearing years. And if we then get that, and that continues into the menopause, exercise can be really, really useful in the menopause to help improve bone density, improve mood, for social aspects. So yeah, if we can nip that in the bud as early as possible, then the benefits are huge, I think. Referrals for pessary supports, and I know lots of GPs practices will do pessaries and fit those. it is something that physios are now starting to do. So I am now trained in pessary fitting, and I fit them with all age groups, but again, similar to the postnatal population, and that can have really, really beneficial implications on their ability to exercise well. These intravaginal devices, I know Lily's going to send this over to you after this talk this morning, but Contiform, Contral, Davine and Ephemia are all the intravaginal devices that can really help with reducing stress urinary incontinence and urge urinary incontinence. Looking at referrals to urology, urogyne, gynae and anal rectal teams if needed, and also if somebody has had a third or fourth degree tear, just really making sure that that OASIS referral, so to the obstetric anal sphincter injury service or team has been made, because if that's delayed, again, it can have quite big implications on a woman's sort of life. And then thinking about prescribing vaginal estrogen for postpartum and perimenopausal vaginal changes. So this is something we're going to go on to in the next slide, but I often write to, this is something that the gynecologists that I know in Cardiff, who see a lot of postnatal women, actually prescribe estrogen for the majority of their postnatal population. And sadly, there isn't enough good evidence to help us with making so vaginal estrogen is an off-license prescription because there isn't enough good quality evidence to support the use of it. But when a woman is postnatal, their estrogen levels, if they're choosing to breastfeed, will remain low for the course or the duration of their breastfeeding journey. If they are if they're not breastfeeding, their estrogen levels will remain low for between 6 to 8 months following the birth of their baby. Estrogen is, the pelvis loves estrogen, and there are so many estrogen receptors within the pelvis, and estrogen is a really important hormone for helping to maintain tissue integrity, tissue rigidity, and helping with the natural lubrication of that tissue as well.
Rosie,
yes,
we've got a question that's kind of on vaginal HRT. So what are your thoughts around vaginal HRT, particularly estrogen for postmenopausal women who have early prolapse? Does that fit in here?
It can be really beneficial because it won't necessarily change the presentation of or the severity of the prolapse, but it can really help with some of the discomfort that you get as a result of prolapse. So sometimes prolapse is made or the feeling of it is heightened because of the friction as a result of the tissue dryness. And so estrogen, vaginal estrogen can really help with reducing that, lubricating the tissue, and also giving a little bit more plumpness to the tissue. So it's not necessarily going to change its presentation, but can it change the symptoms? Absolutely. And it's the symptoms that we really want to think with any presentation at any stage of life about managing, rather than the presentation of the tissue, if that makes sense, or the presentation of the severity of the prolapse. So if it reduces symptoms, makes that woman feel less affected by her prolapse, then perfect. And it's very likely that it would help with that. Hopefully that answers it.
Perfect, thank you. We've got another one about pelvic floor dysfunction, but it might be one we can bring up at the end.
Okay. So yeah, obviously vaginal estrogen is really useful and important during the perimenopause and during the menopause, well, both for vaginal atrophy and then also for seeing if it can reduce and help to manage somebody's symptoms of their prolapse, and also with the condition of the urethra as well, and bulking out that urethra in case if somebody is experiencing urinary symptoms as well. But it's more unusual, and this is why I'm wanting to highlight this at the moment, to prescribe estrogen for the postnatal woman. And all I'm wanting to do with this slide is just highlight the benefits of doing it, but make you understand that it is an off-license prescription. And the study or the magazine that I often refer people to if they're questioning it, which you can read a lot more about it, is this one. So it's the Her Life, Her Health Winter 2023 edition. If you go, it's an online magazine, you can read it, anyone can read it, and you go to page 22 and 23 and it will tell you a lot more about the benefits of estrogen, why estrogen reduces during breastfeeding, and how to manage it with your if a woman comes to you and requests estrogen, or even has pelvic floor dysfunction that you think could be improved with a bit more estrogen in that area. But importantly, it is safe to prescribe it, and for people that are more than 6 weeks postpartum, and they don't need to stop breastfeeding, and it shouldn't affect their ability to breastfeed. So that's actually the end of the pelvic floor side of things. So it might be worth answering that pelvic floor question now, Lily, and then we'll look on.
Yeah. So how do you differentiate pelvic floor dysfunction from symphysis pubis dysfunction? What are the objective measures that could be done in primary care to differentiate symphysis pubis to pelvic floor dysfunction? It's a bit of a tongue twister, that one.
So yes, the pelvic floor can absolutely interfere, or as we said, one of the roles of the pelvic floor is to stabilize from internally that pubic bone, because it's a very small stabilizing muscle, and there are much bigger muscles that attach onto the outside of the pubic symphysis. The chance of it being a pelvic floor problem are very small to little to none, I would say. It's not completely out of the question, but you just have to think about the other anatomy that is involved within and around that pubic bone. But having said that, exposure to pubic symphysis pain for a long time is a risk factor for then developing or that pelvic floor changing. So another risk factor that should have gone in the risk factors is pelvic girdle pain, increases the risk of somebody then developing pelvic floor dysfunction. I would differentiate if the person that you're seeing has got other pelvic floor dysfunctions. So I would then go through as much of a full subjective questioning about their bladder function, whether they leak when they cough, they laugh, they sneeze, they lift, whether they leak if they can't get to the loo, how they're urinating, the frequency in which they're urinating, their bowel function, urgency, frequency, consistency, sexual function, and then any sort of other feelings of pelvic organ prolapse. And if they haven't got any of those dysfunctions, I would say it's very unlikely that the pubic joint pain is as a result of a pelvic floor dysfunction, and it'd be worth looking at it more from a musculoskeletal side of point of view, and assessing adductors, which are a huge muscle when it comes to pubic pain, hip flexors, glutes, and sometimes it can be a referred pain into that area because it's highly innervated because of our clitoris. It can feel pain a lot, or it's much more sensitized to feeling pain. But it doesn't necessarily always mean that the dysfunction is actually there, but it could be the point at which it's being referred into. Hopefully that helps. We are going to go through pelvic girdle pain in a minute. Any others that have come through, Lily?
No, that's great. Thank you.
Okay, so let's take a little bit of a dive into abdominal wall function and anatomy. This is important because, as I said, I'm interested in everything from the ribs down to the tops of the hips, and the abdominal wall is a big part of that. And again, with physiotherapy, it's not something that we really focus on with our core training that we do, and it's definitely a specialist area that I've developed in my career as a result of going into women's health. So the main thing that we would see in the female population is a something called diastasis, and particularly for the GPs amongst you, this might be something that is a request from postnatal women for you to assess with them, or that it might be a concern of theirs, either in pregnancy or postnatally. It is a bit confusing because it can be known as lots of different things, but it all is exactly the same thing. So it's diastasis, divarication, rectus diastasis abdominis, RDA, abdominal gapping, same thing, rectus abdominis diastasis, RAD, or abdominal separation, mum tum, mummy gap, all of those sorts of things. All it is we have a natural structure within the center of our abdomen, which is actually technically known as an aponeurosis. It's a collection of tendons that our muscles are attaching to, and normally those tendons would actually attach to a bony structure, but the tendons have created a nice solid fascial sort of support system so that they can do their job, which is to pull, and that happens to be this white structure called the linea alba through the center of our abdomen. It inserts up at the xiphoid process and goes all the way to the pubic bone, and it changes in its thickness throughout it, which we're going to go through in a minute. But a diastasis is when there's been a widening and also a lengthening of that linea alba, and therefore the integrity and tension of that tissue has reduced. It can happen with anything that changes your abdominal size, so a pregnancy most commonly, but it can also happen to anyone else. It can happen to men who have got increased abdominal mass, and it can also happen to anyone that has got an ascites as well. So it happens in 100% of women, pregnant women in their third trimester. So it really isn't anything to worry. It is something that is just naturally occurring to allow baby to grow within the woman's abdomen. But we do know that having it can lead to negative body image implications and reduced self-esteem and quality of life. Normally, by 8 weeks postnatally, 2/3 of women's linea alba will have come back to within a functional range, and that functional range is anywhere between 0.5 and 2 centimeters of width within that space, which I'll talk you through in a minute about how to assess that and what that means. So actually, only really 1/3 of the women that you might see need help or rehab with their diastasis, and that is actually more to improve the function and the ability for the abdominal wall to cope with loading, possibly more so than reducing the width of that space, which we'll go through again in a minute. I've linked the physios. There's two world-renowned physios really in this area. One Irish physio called Grania Donnelly, and then Munira Hudani, who's a Canadian physio, and both of them are really paving the way for improving the understanding, both for patients and for other physios, to in this area of health. And it as with a lot of women's health things, it's very poorly researched, but that is improving and it is changing. But I always use this analogy that I've seen one woman after 3 of her pregnancies, and after each pregnancy I've used an ever so slightly different approach in helping rehabilitate her diastasis, because the evidence and the tools or the advice has changed that quickly. So that's over a 5-year period, and the evidence has changed so quickly for each of her different pregnancies. And she said, "But Rosie, last time you told me not to do this." And I say, "Yeah, but now we know that it's safe to do this." So it does change quite quickly, and it's good to sort of keep on the keep your finger on the buzzer in terms of staying up with the current research if you can. So the abdominal wall is actually a really important part of our anatomy. It helps with abdominal and pelvic organ support, orifice support. So if you think about when you go on a plane and you feel that change in pressure, you actually close your nostrils and then blow out through your abdomen to change that pressure system within your abdomen. Your breathing, so it helps with exhalation of a deep breath, and it has to expand as we inhale. It helps with eliminating anything, coughing, vomiting, helps with our birthing, defecating and urinating. And then it's so super important for all of our movement controls, our trunk, our head control, our neck. So if there's a dysfunction in it, it can then lead on to changes to any of these functions that we take for granted often. Just a whiz through on terms of the anatomy. I'm conscious I don't want to go over time, but this is our most outer portion of our abdominal musculature. So the external obliques, it is our most superficial abdominal muscle, and this white stuff is this aponeurosis that we've spoken about, which you'll see will get thinner as we go down the layers of abdominal muscles. But this action, it pulls that chest downwards, so to compress that abdominal activity, and then it also does some of our side bending and rotation. Our rectus abdominis is our next lowest abdominal muscle, normally seen as our six pack. And yeah, it keeps and brings our rib cage down to our pelvis. And then it can help with lumbar flexion and then that posterior-pelvic tilt as well. Our internal oblique, you can see this aponeurosis is getting thinner. Helps with respiration and rotation and then side bending. And then our transabs or transversus abdominis is a really important stabilizing muscle for our lower back. And it's creates that sort of narrowing, corseting effect of our abdomen. It's often the muscle that women, once they've had a pregnancy, find that they've noticed the biggest change to their abdomen, and it's most likely because of this muscle having stretched and lengthened as well. And that's what we need to remember with diastasis, is that it's not just the stretching and lengthening and widening of that linea alba, it's actually all of that musculature that has a change within it as well. This is just an interesting thing to look at and know that this linea alba changes in its thickness as you go down the abdomen. So it's thinnest up here, closer to the xiphoid process. You've really only got the external oblique and the rectus abdominis tendons creating the linea alba up here. And then you've got a little bit more thickness here, where you've got the internal oblique and the transabs joining. And then the thickest portion of the linea alba is actually underneath the belly button. Diastasis does happen down there, but it's only in 1/3 of women. So it's less likely for diastasis to occur under the umbilicus and much more likely to occur just above the umbilicus here or further up. So how does intra-abdominal pressure relate to what we're talking about, and why is it important? So pressure is always something that's changing within our abdomen, and as we saw on the abdominal wall function slide, it is a sort of a moving of that abdominal pressure, either at the pressure increasing or reducing to help some of those functions. And our core muscles have to respond to this pressure system to help whatever the function is in hand. And every movement creates a relative rise or a relative reduction in that intra-abdominal pressure. So if these tissues are struggling to respond to these demands, then we can see a reduction in strength and reaction and endurance, which is really important for then our overall function. For postnatal women, it's really important that we've got all of the ability of this to look after the children and the babies and the toddlers that we might have to afterwards, after pregnancy. So what is are important objective markers when it comes to diastasis. We often hear a lot about the width of the structure, and I would argue that it's definitely not all about the width. It is important, but I would say that the depth and the tension are better indicators of muscle and tissue integrity. And it's that integrity that overall is what we want to try and improve with over time and with training. Normal ranges of width are between 0.5 and 2 centimeters within that space. So most people wouldn't necessarily know what their width was before they go into a pregnancy, but it could be quite normal that they have anywhere between those measurements before they even get pregnant. So if we're then looking to try and reduce this width in the postnatal period, we're never going to try and get it to 0 because that's not possible. But we also don't know always what their baseline was either. And you can function with lots of width across that gap as long as the integrity of that tissue is better. And that, as I said, is more likely easier to measure with the depth and the tension. So a study in 2016 found that the depth of the tissue is actually that better indicator of the muscle activation, and whether that tissue is able to then stimulate tension across that sort of gap that we've got in our abdomen as a result of the pregnancy. Sometimes in creating tension across the gap, you're actually going to widen the gap. So that's why width isn't always that important. And then the tension shows us how well that tissue is tolerating and then responding to load. Again, with diastasis, we often hear or see a lot about sort of doming, and doming isn't actually isn't a problem with diastasis. Doming is just a sign of that pressure system leaking out through the path of least resistance. So if you think if there's constant changes of pressure within your abdomen, your body will always take the path of least resistance. And that pressure is just saying, oh, okay, well, it's really hard over here where there's really nice thick tissue, and it's not so hard here. So I'm just going to push a little bit more of that pressure out through that gap. And that results in this presentation of what's called doming. Doming is generally very safe. There are 2 types of doming that we can see. There's and it's down to what you feel really in that doming, that depends on what we want to see and what you should be doing. Soft doming is where the tissue is, when you see the doming, you can still penetrate your fingers down into that space, and therefore the pressure behind that abdominal wall is still relatively low. So if you think about a fizzy water bottle, if you can sort of scrunch it and pressurize it and move it, then the gas that has is in that bottle, that it's still like not sort of max. When you take the lid off, you're not going to hear this, big sound. If you get the same fizzy water bottle and the walls of the fizzy water bottle are very hard, then you're more likely, when you take the cap off, that you're going to get a real sort of expulsion of gases, because the pressure system is quite high behind the scenes. So if we then see that doming and now we press into it and it's very hard, then it's much more likely that the tissue is at higher risk of something like a hernia, and that movement that the person is doing is something that we want to try to avoid. So doming it's not as cutthroat as doming is bad and therefore we shouldn't see it. It's what's happening when we're doming, and to help allow us to know what we can and can't do. So hopefully you'll be able to see this. So this is a video of me assessing myself for diastasis, which I don't have. So you're not going to necessarily see my fingers going into that gap. But at rest, I'm just going from my xiphoid process all the way down to my pubic bone, and with my 2 fingers just palpating that midline. I'm now going to take that tissue under tension, bringing my chin to my chest, and I'm using the same technique to go down that full central line. If my fingers were to dip into that space, or I was to feel some softness, I could then use my fingers side by side to sort of measure what I'm seeing. You can, so what you're seeing now is that I'm exhaling as I do this. So you can do it under different, it's just basically showing different techniques for how you tension that tissue. And sometimes exhaling can just change the tension that you're feeling within that space. Does anyone want to watch that again or have any questions about that?
No, no further questions at the moment.
Okay. So what can be done about diastasis? So physio is definitely really helpful and should be the sort of first port of call with diastasis. Particularly pelvic health physios, we're often the ones that will have had the most training within this area of health. But we really need to be progressive and use optimal loading for the abdominal wall. And that's been shown so far to have the best outcome for improving the function of that diastasis. We're not looking to close the gap. Reducing the width of the space can happen, absolutely, but it doesn't change the function or the ability for that abdominal wall to work as well as it can do. And it's more that gap has got very good tension in it and integrity within it and is as shallow as possible. GPs can refer to women's health physios, absolutely, and then trying to reduce fear is one of the big things with this. Unfortunately, the world of Dr. Google and Instagram will have women think that there are do's and don'ts in terms of exercise categories for diastasis, and that they could be doing damage to their abdominal wall if they do too much or aren't doing the right things. And it's very, very unlikely to happen that you can damage this tissue or make this worse. It's the act of having had the change to your abdominal pressure, which is the pregnancy, that has changed this tissue the most. And unless, I always say, the physio clinic that I work at has a big car park outside it, and I always say, unless you go and pick up all the cars in that car park, you're unlikely to cause a problem to this tissue or worsen it. Actually, if you're doing things and progressively getting stronger over time, the abdominal wall will likely respond to that and improve its function, and therefore your diastasis will likely improve as a result. Sometimes the width and the gap doesn't change, and then I would but if they are able to do everything that they want to do within their ability, then I would call it a functional diastasis, and it's just something that is part of their new anatomy now, and it's something that they have to live with. So other things that pelvic health physios can help with are pelvic girdle pain, which we touched on briefly with the question. Pelvic girdle pain is actually a bit of an umbrella term for almost any pains that happen within from your belly button down to the tops of your hips. So sciatica will come under that. This pubic symphysis dysfunction will come under that. Hip pain will come under that. And basically, it's been termed by the European guidelines because lots of the reasons for why we get pain in pregnancy come down to the similar factors, which is the change in load, the hormonal changes, and the abdominal stretch to those tissues that often support that pelvis. It can be treated really safely at any stage during pregnancy, and the sooner it's treated, generally the better. And if it's left untreated, it can continue for up to 2 years after birth. It's very unlikely that that does happen. Normally it's gone within about 2 weeks after birth, but it can continue. They found that really the main risk factor for it, so these are some of the places that you can develop pelvic girdle pain. And the main sort of risk factor for it is actually a prevalence to having had any pains within that area previously, and those tissues will have then had a sensitivity or be more sensitized when then the change comes about, that is pregnancy, to then show signs of feeling sore again after that. But some of the other risk factors are PGP in other pregnancies, multiparity, heavy workload or a repetitive movement with your working, workplace ergonomics, and increased BMI, and weight pre-pregnancy, and hypermobility as well. So this is what we just touched on, that it's actually an increase in tissue sensitivity rather than potentially changes in hormones, and it's almost definitely not relaxin that's causing the problems. It's relaxin is within our system, and it's a hormone that increases definitely in pregnancy, but it's not going to all the joints and making them all soft. It's actually probably, yeah, the sort of tissues that have been sore in the past are just under more load as a result of the pregnancy. So physio is a really great stage to start with, and I know that both in Bristol, both Southmead and the BRI have got pelvic girdle classes that you can send the women into, and they'll be taught on all of these things. So whether belts help, sleeping patterns, their sort of awareness with their posture, pacing, paracetamol, pain relief if that's useful. And they are actually a really good service to help just inform women and reduce their improve their understanding, of why they've developed pelvic girdle pain. And then I think they're then offered one-to-one physio if needed after that, if it still hasn't, they haven't got on top of it. GPs can refer to these physios. The earlier the better, really, and it can be really effective seeing women earlier to help their pain levels and help them to understand how to manage it as best as possible throughout their pregnancy. Ease apprehension with movement. So sometimes women can feel that they are going to be doing damage to themselves or the baby when they get this pain, and that's not the case. But they just need to understand what's triggering the movement, look at sort of a 48-hour pattern of what they've done previously that might make their day, that bring on their pain later on. Large tubey grips or pelvic belts can be really useful. The swimming, there's free swimming to pregnant women, and this can often really help with easing discomfort. And then this charity, the Pelvic Partnerships, is a really good reference point for helping women to understand it and giving lots of useful tools to that as well. Other things that we can see, particularly in pregnancy, is rib pain, which is as a result of that fetus growing, and then carpal tunnel syndrome, which is just that increased blood volume and swelling. The POGP are the pelvic obstetric gynecology physiotherapists have got some good leaflets on their websites for both of these things as well. Briefly, we're just going to touch on the menopause, and then we're going to go to questions. But the menopause is another area of our life when pelvic health physio can help. And it is generally because of this reduction in estrogen and how important estrogen is for maintaining our urinary function and our that reproductive systems. They are all, that whole area is lined with estrogen receptors, and this area can really feel the effect of not having that in that area. So like we touched on with the question, HRT can be really useful at helping to actually maintain some of those pelvic floor dysfunctions, maintain some of the pelvic floor functions and reduce the dysfunction, or help to maintain comfort within that area as well. And it's definitely a time to start that pelvic floor muscle training. As we said, you want to be doing your pelvic floor exercises every day, so that when you get to this stage in your life, you can sail through it knowing that you've been training that muscle to cope with the changes that are about to come. And really encouraging women to start or maintain their strength and impact training can be so useful and helpful to maintain muscle mass, and that bone density as well. So these are some good learning resources for you. I've sent Lily, who's going to send it out with this presentation, a document with loads of different sites that I use and I recommend that you can sort of just go to when you have somebody in front of you, and there might be something on there that helps you with your clinic, or even if you've got a little bit of spare time and you want to learn or read up a bit more about some of these areas, you can then go to them and find out a little bit more about them. Yeah, so that's the presentation done. I will let Lily see if there's been any questions at all.
Thank you very much. No questions so far from the ones we've already had. Does anybody want to put on their mic now and ask any questions? Absolute silence. Brilliant. Hopefully you found that very useful, and thank you very much, Rosie, for that very informative session. Like Rosie said, I'll be sending out our team will be sending out a PDF with some useful links, the recording of the video and the feedback form, which is in the chat now if anybody wants to do it now, but it will be sent again later as well.
Yeah, and I can always be emailed as well if
We do have a question from Justine. Justine, do you want to pop yourself off mute? Unless that was an accidental hand raise. Oh, there you go. We'll quickly type. Justine's mic isn't working. So said you mentioned the prescription of intravaginal devices.
Yeah.
But there's more to go. Would these women need an assessment prior to getting these on prescription?
No, so they are yeah, readily available. You could, I presume, would need to speak to the GP about the problem or the prescriber about the problem, but they don't need a pelvic health physio assessment. And they all come with their sort of instruction manuals, and you just want to make sure that they're understanding that and that they know how to insert them and remove them, and reduce the use of them if they are causing any discomfort. But some of them are a bit more comfortable to wear than others and a bit more effective. So yeah, it just is going to come down to a woman's choice. The most comfortable one I would say is the Contrail ActiGuard, which is the one I think that might not be on prescription, but I can double check through the NHS. And it's almost like a tampon. It's like a foam tampon with an applicator. So it's sort of similar to using and applying one of those. And the act of the foam just then stents that urethra, and very often women can then go about their day and not be so affected by that feeling and that sensation of the urinary dysfunction that they've been having.
Brilliant, thank you. You got any more questions? Here it says, thank you very much and amazing. Someone said, would you be able to signpost me to a Cardiff consultant?
Oh,
You mentioned about vaginal estrogen and breastfeeding mothers. Was that on the signpost to the individual who wrote that article?
Yeah, I think I mentioned that I work with some of the Cardiff consultants. So they are Mr. and Mrs. Ball, but they haven't necessarily written that paperwork. So the the article that I signpost, if I'm asking a GP to prescribe estrogen, I would signpost them to that article that I put in the slide, which is in Her Life, Her Health magazine, and it references the current evidence that there is on the benefits of prescribing estrogen to breastfeeding mothers. And I can send you the link to that, Lily. And then, yeah, I'm doing my pessary training under Mr. and Mrs. Bowell, and they're the ones that I know that would prescribe it for breastfeeding or postnatal mums a lot, and they follow that advice that is within that article that I've referenced.
Brilliant, thank you. Yeah, if you forward on that link, if it's not already in that PDF, then we'll share that. But the link's in the slides anyway, isn't it?
Yeah. Definitely.
Okay. Thank you, Lisa. It looks like someone else is trained with Mr. Bowell.
That's good.
Brilliant. Perfect. I think that's it. We've come to an end. So thank you very much, everyone. And thank you, Rosie.
Thank you very much.
Everybody